Thank you, Norma. Thank you, Norma, and on behalf of all the folks at Better Health Greater Cleveland, we're grateful to share the stage with such an august group at such an exciting place in such interesting times. I'm here to tell you a little something about Better Health's unique role in our community. Our shared vision is to make Northeast Ohio a healthier place to live and a better place to do business. And so this becomes for a little while a convening event for our 11th biannual, that's twice a year, public report, celebrating our achievement and improvement in 2012 as reported in our community health checkup. This time, if you've been involved in these sort of convening events before, we're doing things a little differently. In particular, in an effort to be greener, the summer 2013 executive summary of our report is now exclusively available online. There's a card in your bag indicating, and you can visit that website to find a full report on what we're doing, where we're going, and the results to date. The picture on the bottom, well, I should point that way, huh? The picture on the bottom of our, I feel like a weatherman, of our executive summary, is part of our 12th Learning Collaborative Summit held this past March, I guess. And I hope it helps frame for you our collaborations. At Better Health, we provide a safe space for competitors to collaborate. And together, bringing data and insights from all, we're driving better healthcare for everyone in this room and everyone outside. Our new report features video commentaries from J.B. Silvers and other luminaries representing the range of Better Health's reach into our community, discussing how Better Health is making a difference in the care of our residents and in the outcomes we've achieved. So I'm here to briefly highlight some of Better Health's achievements presented in our new report and to show you some of the ways in which Better Health and the commitment of its partners to collaborate and to share data can help us achieve the goals that we've been talking about today. Our new report describes more people than ever in all, over 140,000 adults receiving health care in Northeast Ohio, including more than 34,000 patients with diabetes. 4 out of 5 of our diabetes patients also have high blood pressure. And in total, we report nearly 135,000 with high blood pressure, as well as more than 6,300 with heart failure and 1,700 that suffer from all 3 of these conditions. Our new report describes 638 doctors and other care providers from 8 health systems. And these are the good guys who are committed to transparency and to reporting to the public on the care and outcomes of their patients. Better Health works for everyone, from Care Alliance, part of which is just down the street, where 80% of the patients are homeless and the rest live in public housing, to the Cleveland Clinic and Kaiser Permanente and the VA and Metro Health and Neighborhood Family Practice, Neon, and North Coast Health Ministry, most of which are represented by folks here. These sites are to be commended for their commitment to collaboration, to transparency, and to electronic health records, as all 8 of these systems now have functional electronic health records and have been reporting their data on all of these patients since we got started. So a few highlights of our new results. First, we'll compare Better Health's achievement in 2012 to the most recent available data from the National Committee on Quality Assurance and HEDIS on 6 of their key measures, of comprehensive diabetes care, including keeping blood pressure under control, good control and avoiding poor control of blood sugar as measured by hemoglobin A1C, keeping cholesterol controlled, getting a diabetic eye exam, and managing kidneys through screening for trouble or the use of particular medications to avoid further trouble. NCQA provides data for U.S. health plans. We'll start by looking at commercial health plans, which probably affect most of the people in the room, and comparing to Better Health's commercially insured patients. So I'll just put a little check mark to indicate when Better Health's achievement is better than the national average. And so across these 6 measures, we're better on all 6. And in fact, the little gold arrow there means to indicate that we're not just better than average, but we're better than the national 90th percentile of all health plans in the U.S. for commercial payments. So that's great news, and we're delighted by that. Thanks. I'm not in any way responsible, but I'll take the acclaim. So that's great for all of us with commercial insurance, but what about Medicaid patients? Well, that too, we're good on Medicaid and the uninsured and Medicare. We get all of them. We're better than the national average on all of these measures, and in fact also on the other 4 measures that I didn't show you of comprehensive diabetes care. So the quality of care that's provided in Cleveland by these measures seems to be quite strong, although there is still certainly work to do. So improving primary care means more than just matching a series of national standards, although that's a good starting point. It means improving population health on measures that matter, and matter to the patients as well as to us, including things like blood pressure control and weight control and tobacco use that particularly affect the chronically ill patients that we look at most of the time as part of better health, but affect everybody. They affect me and they affect you. Too. Among our diabetes patients, if you look at the graph, the numbers still leave a lot of room for improvement, even among our patients with diabetes, but without depression. And in a moment, I'll show you the results for our depressed patients. But just in the group without depression, still only 72% have their blood pressure controlled. 78% are remembering not to smoke. And a mere 35% are just not obese, meaning 65% are obese. And then if you look at our patients with both diabetes and depression, so depressed here is blue, sorry, and not depressed there in the pink, they show even worse results with blood pressure and weight less likely to be in control, and now only 2/3 of patients are not smoking. And so depression status is a new breakdown for us at Better Health, and there's a detailed report available on our website looking at how depression and diabetes work together for some of these key issues. Next, most of our reports deal with scores that we've developed locally based on nationally endorsed standards. Our diabetes outcome score, for instance, looks at how well patients and their providers did at meeting goals for controlling blood sugar and blood pressure and cholesterol and weight and smoking. Since 2007, the number of patients that meet our standard has increased from 9,500 to nearly 14,000 in a 5-year window. And overall, we've gone from about 37% of our patients to 41% of our diabetes patients meeting that standard. In high blood pressure, as a second example, we should tell you that we like to report these scores broken down by other factors, for instance, the type of insurance a patient has. For high blood pressure, we report in 2012 that over 70% of our Medicare and commercial patients have their blood pressure under control, while this is true for only a little over half of our Medicaid and uninsured patients. Of course, all of these stories look a lot better when you compare them to the national average, as described by the Centers for Disease Control. So Better Health sites actually have a better rate of high blood pressure control across all 4 insurance types than the national standard of 47%. And across our 56 practices, 54 beat this 47% standard. So this means that at 54 of our 56 Better Health practices in 2012, those 54 beat the national average for control of high blood pressure, keeping it below 140/90. And overall, you can see the little yellow bar at the left of the screen, we're at 69% control for more than 134,000 patients. So we've got a lot of work to do. That remaining 31% is not going to be easy, but we've made some good progress. So I want to close by honoring our partner practices with our 2012 Gold Stars. The practices listed here have earned special recognition for, in this case, their outstanding improvement, and here their high achievement on crucial measures of care and outcomes for patients living with diabetes, high blood pressure, and heart failure. And the wonderful news is that all 8 of our participating currently reporting systems have at least one practice receiving this recognition today, which is absolutely marvelous and deserves a round of applause. So congratulations to all of our partners and to their patients. So I want to encourage you to look at our executive summary and explore our new data website, and you'll find the details on all of them if you go to the URL that's on the card that's in your bag. Together, and if you go there, you'll be able to see the difference we've made so far and catch a view of where we're going next. So together, we'll make a difference in Northeast Ohio. And at this point, I'll turn the microphone over to Dr. Cebul, who is the president and director of Better Health. Thank you. Go ahead.
Thank you. So Tom sometimes comes to work. He's normally auditioning for a play or performing somewhere. He's terrific. Anyway, before I get started, I'd just like to thank Patty Reed and Norma Vaganti for engaging Better Health Greater Cleveland in this process of helping to transform the workforce using health information technology. It's been a wonderful experience. Rita Horwitz and Bonnie Hollopeter and Carol Kashub are especially responsible for helping to coordinate this event today. I'd also like to thank Tom, whose joy both in assembling and aggregating and reporting the data enables me to do a lot of the other things that I like to do, and I thank him for that. He and Diane Solov and Chuck Greinert are our webmeisters extraordinaire, and so as you see changes in our presentation of data, it's due to the work of Tom and Chuck and Diane Solov. But before I begin my presentation, I'd also like to welcome Dr. Akram Boutros, who's Metro Health's new Chief Executive Officer and President, now in his 20th day on the job. For many of you, this will probably be the first introduction to Dr. Boutros, so a word or two about him from my limited experience might be worthwhile. I've had a few opportunities to chat with him. He's a man of vision. He's got a big heart and a hard head. He has a good sense of humor. We share, he and I, a really strong commitment to transparency. And I really am very grateful for that. He's going to be good for Metro Health, and he's going to be good for Cleveland. And finally, for those who might be concerned, he's promised me not to return to Long Island for the foreseeable future. So please welcome Dr. Boutros. Could you stand up and be recognized? So, there you go. Good. Because Tom's already shown you a few tidbits of the current report, which is our 11th report since 2008, and giving you directions for how to see it in its entirety online. And because there are a number of folks in the audience who I assume do not know Better Health Greater Cleveland so well, I'll focus my presentation this morning on the bigger picture of what Better Health is, what our values and methods are, and the fairly audacious goals that we aspire to achieve. As an academic, I always have to follow the convention of opening my talk with disclosures relating to my conflicts of interest. They are in the book, but I don't think I wrote them as explicitly as I have here. First, I confess to a very strong community self-interest. I was born in Cleveland when there were more than 900,000 residents, and when I returned with my wife, Mary Scott, in I won't tell you, there were 500,000, so you ought to be able to figure out about how old I am. So along with my partners in Better Health, I'm hoping to help this region become a healthier place to live and a better place to do business. And Tom has already mentioned that as our vision. Second, I have blazingly stolen ideas from Dan and Chip Heath and their book Switch. And through them, I stumbled upon Jerry and Monique Sternin and the positive deviance approach to change, and I'll share that approach this morning. Third, I'm a general internist. And a generalist who advocates for patient-centered primary care of patients, not just organs, and how the meaningful use of electronic health records can make it easier to do the right thing at the right time. Finally, Better Health receives financial support from some of you in the audience. I find no conflict with that, but I thought I should mention it. So, I've already shared with you the common vision of the primary care partners in Better Health to help make Northeast Ohio a healthier place to live and a better place to do business. This means doing our best as physicians to provide accessible, highest quality care for our patients at affordable costs for both public and private employers and for patients who are facing larger and larger out-of-pocket expenses for the services we provide, and to keep them healthy and out of the hospital when possible. Sorry, Akram. Our abbreviated mission statement, which is here, came directly from an anonymous survey that a consultant conducted for us last summer. In short, the respondents knew the competitive nature of our healthcare market, and it is a very highly competitive market as compared to others in the country, and said that Better Health providers provide a safe space for competitors to collaborate. By providing the same kinds of data on the same important health conditions as Tom just described, by publicly reporting their results, and by sharing their best practices with their cross-team colleagues. They are competitors collaborating. We thought this was pretty compelling, and it enabled us to drastically shorten our earlier statement. This slide begins my blatant theft of ideas from Chip and Dan Heath. Is Dan Heath here? Not yet. So the man in the picture here represents hospitals or employers or physicians who think they know where they want to go, but they don't know how to get there. A commonly used metaphor for what we're doing in healthcare these days is trying to assemble an airplane while we're flying it. And even while the instructions are changing while we're in the air. It's no surprise that many places are following this wavy line. It's a stunningly challenging time. In Better Health, we've had the audacity to think that we can shorten the path. For those who've read Switch, it's a terrific book. We're behaving like the elephant who goes straight ahead, following his instincts at the same time that the elephant's rider wants him to veer right and then left and then right again. And I must say that listening to Governor Kasich last week and then Greg Moody this morning, I'm very impressed that they are, like the elephant, marching in the right direction without regard to a lot of other places and states that are doing things left and right and left and right. We all know that we're more likely to get a postcard from our veterinarian for our dogs, although, frankly, Judy Murphy this morning said that your mother is getting all sorts of... Now, this is not necessarily the highest quality care, but for us, for Mary Scott and me, we basically get messages from our vet. When our kids were small, we got messages from the shoe stores. You know, they should be ready for it. But in healthcare, there's not that sense of accountability. If we're following the dollars, though, I think your 88-year-old mother, it was not necessarily well served by the notion that she should get a screening colonoscopy at that age. Paper records are, from my point of view, the enemy of coordinated care, period. It's just not, if you're in seeing a doctor who's caring for you with paper records, he's behind the times, she's behind the times, you're not as able to get care coordination. We're paying now for the volume of services delivered and being told that we're receiving the best care possible. If we can see Greg Moody's slides with regard to coordinated care or fragmented care versus the future, this is what he was talking about. But we're being told, so we have fragmented care, and we're being told that we're getting the best care possible. The United States is number 38 in the world for almost every standard measure of health. We spend more than twice the amount on health per capita than the next most expensive country. This is silly. This is silly. We should be looking for higher value that is quality and at lower cost. Where we're going, I think, here is we're going towards more patient-centered, coordinated, team-based care. That is what Greg Moody talked about. Using electronic health records in a meaningful way, which is what Judy was talking about earlier, as described by her, and towards paying for value, which is simply measurably better quality at an affordable, acceptable cost. In terms of who our stakeholders have been and will or should be, as the state of the healthcare world is, virtually no one is accountable. And again, Greg Moody had in there, physicians aren't accountable, hospitals aren't accountable, insurance companies aren't accountable, pharmacy, et cetera, emergency departments are not accountable. And most parties have self-interest that does not align with the higher quality at affordable costs. In an ideal future state, my partners in Better Health agree that primary care, which I heard for the first time today, will be incentivized in the DME money that will go to training facilities, but that those training primary care physicians disproportionately will get the dollars. He said $100 million at risk. So primary care should be accountable for delivering demonstrably high value care to their patients, to the employers who want healthier employees, and to the taxpayers. Now, here's the alternate reality. We're not naive. We're aware that there is an alternate reality. How many of you have driven along the freeways and seen signs like this? A very good number in the audience. The hospitals attempting to grow their market share by enticing people who've got sniffles or sore throats or something to the emergency department for non-emergent problems. This is silly. This is silly. Follow the dollars. It's really not about being able to get your broken limb or your smashed pelvis or something like that cared for more efficiently. You're driving along the highway when you see this billboard. You know, it's silly. There's no continuity here. I have very good friends in Metro's ER who are terrific doctors, but they would concur. This is not continuity care. This is not where care is coordinated in a natural kind of way. So instead, we are pursuing the patient-centered care approach. We have helped Better Health Greater Cleveland and our coaches, including Bonnie Holopeter and others who are in this room. We've helped them get recognized by the National Committee of Quality Assurance, NCQA, for patient-centered care. These are 27 practices in Northeast Ohio that are our partners in Better Health Greater Cleveland that have gotten the highest level of NCQA recognition. And included in folks who are here in this room from Neighborhood Family Practice, Care Alliance, and North Coast Health Ministry. So Care Alliance is the site that Tom talked about, 80% homeless, 20% public housing. North Coast Health Ministry has been a free clinic, and Neighborhood Family Practice serves a disproportionate number of Hispanic patients on the west side. They've all gotten level 3 recognition by NCQA in the last year. These are a couple of favorite expressions that I've taken from the literature. You can't manage what you don't measure. We all know that. And Edward Deming, who is the sort of the godfather of quality data of CQM and TQI, he said, "In God we trust, all others must bring data." I think that's very good. But paper records don't really provide for accountable, actionable results. On the left this is how I grew up in medicine until 1999, when Metro became fully deployed in the Epic electronic medical record. This is what we had. I don't even know where the paper records are these days. But in the paper record room, you say, well, how many patients in this room have diabetes? How many are at risk for amputations? And you can't answer those questions. You just can't answer those questions. And this is our favorite prosthetist. And there were 500, and Tom, do you remember, 508? Oh, no, 485. We actually did better. About 485 amputations of diabetics in Cuyahoga County's hospitals last year. 485. you can't manage those well if you're using paper records. And the electronic health records, we've been pleased to be able to publish this. Those of you who've seen these presentations before know that we've celebrated this. I think Judy and Chitra both know Farzad Mastashari, who's the director of the Office of the National Coordinator. He is the national coordinator. And we published our results comparing both quality as well as improvement in quality over time in the Better Health Greater Cleveland, Northeast Ohio region, showing that those, after you've done all the accounting for living under a bridge and so forth, that the electronic medical record practices did much better than the paper-based practices. And Farzad came out to Cleveland and walked through and really was very diligent in standing behind the receptionists and talking to the nurses and seeing what our care plans look like and that sort of thing. So it was wonderful to have him out. We're also documenting that our poor and our uninsured do least well. And if you go to our website, you'll see a lot more about this. But if you're African American, low education, low income, Medicaid, or uninsured as compared to Medicare, high income, high education, or white, you do worse. That's not a surprise. We're doing our best. And even as we make improvements, this is blood pressure by race, even as we're making improvements over time, we've got a long way to go. And you see that the whites are doing better than the African Americans, although the Hispanics, in part because of the strong work on the west side of Cleveland, where they live mostly, of neighborhood family practice and the metro health practices, we're doing better with the Hispanics. So the triple aim has been mentioned 2 or 3 times this morning. I'll just say, we aspire to achieving the triple aim, which is basically better health, better care, better health at lower costs. And the notion here, and I say this in this sequence, is that better care leads to better health. Well, for some anyway. I mean, there are lots of other factors, social determinants of health that matter as well, but better health, better care should lead to better health. So what we're using, now we're moving into the Jerry Sternin. I'm not really borrowing from him because we had discovered it before I'd read the book, but he sort of stumbled on this positive deviance approach. And basically using data to find bright spots, to find the people who are the positive deviants. It sounds like an oxymoron, but anyway, so here are all of the practices. This is change in blood pressure control. It could get worse to the right of the bar over from 2009 to 2011, or you could have gotten better to the above the horizontal line. And the red practices here are all from the same system. They were the best improvers. They're all from the same healthcare organization. And you have to say, who are they and what did they do? And so they are Kaiser Permanente. I saw Ron Adams here earlier. Is Ron here? So there's Ron Adams. So this is, and so what do we do? The Kaiser is going to be teaching the rest of us how to do better. They are not only improving the most, but they are, if you looked at just achievement as opposed to improvement, they are also achieving the best in care of African American patients with high blood pressure. So Tom mentioned the mission, it's this safe space where competitors collaborate. And so this is basically, I think this is the same picture that Tom showed earlier, and this was in fact the March 13th, 2013 collaborative Tri-C corporate East, 200 plus people, physicians, nurses, administrators, mostly from primary care, and we're increasingly having folks from outside, from hospital systems and so forth. So the question is, how does this work really? And I'm going to show one example that some of you will be familiar with. But we're using the data to find the positive deviance. And so you look here so one of the standards, as Tom illustrated, for our diabetic patients is to vaccinate people, everybody with diabetes, against pneumococcal pneumonia, bacterial pneumonia. And everybody agreed, the group agreed that this was an important standard among patients with diabetes and all older folks as well. And so these A's down the left-hand side of this graph basically mean that it's the same system. All the blues are the same system, just like the other ones were Kaiser. And so the highest, in 2008, the highest performers were all in the same system. And so who was that system? Well, the system was represented by these nurses right here. This is a workforce transformation initiative today. The nurses figured this out, and they figured it out with Peter Greco. Peter, are you here? Yeah, and they figured it out with here. So basically, the answer here is sort of everybody working at the top of their credentials. You understand, people recognize that term. Everybody, instead of having physicians doing things they shouldn't do, or nurses doing things that really don't need to do, or medical assistants doing things that the receptionist should be doing, etc. Everybody should be working at the top of their credential. The nurses figured out that if they worked with Peter and figured out a way to make sure that every person who was coming to the clinic on any day, in any place in Metro, would be known as to whether or not they needed a pneumococcal vaccine or not in advance of the visit. And as they were seen by the receptionist would give them a brochure about pneumococcal vaccination. The MA or the RN would do the vaccination before the doc even saw them. It just we had a goal, we used IT properly, it became a team process to address that goal, and that's what they did. They did it without us, they did it with Peter. And so what did we do? So we went to the Learning Collaborative Summits and shared the best practices. This was simple. This is not rocket science, but it's changing the workflow. It's changing what people are doing, and it's all goal-directed, facilitated by information that is provided through the electronic health record. So we shared that at the Learning Collaborative Summits, and you see in 2007, the baseline for everybody other than Metro was 66%. The baseline for Metro was 88%, and everyone has gone up a considerable amount. That is a very high rate of vaccination. It's about 78 or 79% in the whole region of Better Health Partners at this point in time. And it's through the translation of successes in one place to other practices in the region. So the next thing is basically that we would hope that better care would lead to better health, and that better health would lead to lower costs, right? So that's the triple aim. And so we basically tested, and this was really sort of provoked by the Robert Wood Johnson Foundation, who funds us mostly, and they said, you said that you were going to be able to save costs, and we didn't have, Dan Paoletti, we didn't have health information exchange at that point to be able to tell us that, in fact, our providers were accountable for fewer, or accounted for fewer hospitalizations during the course of Better Health. So we used a different data set that Dan Paoletti also produced, which was an all-payer database, to look to see what happened after we started reporting in Cuyahoga County to those hospitalizations that are called ambulatory care sensitive hospitalizations in Cuyahoga County, comparing them to Summit, comparing them to Franklin, comparing them to Hamilton, comparing them to Lucas, and comparing them to one other. Montgomery, which is Dayton. Anyway, so we compared Cuyahoga's change in, and then looked at, and in fact, there were reductions in Cuyahoga County as compared to all of the other counties, which we were able to estimate using some fancy models. We had some expectation that we might have done this because not only were we reporting other good things that were happening in terms of achievement improvement, but we've also broadened the number and base of patients for whom we are reporting in this Northeast Ohio region. And as a result of that, we are quite confident that we've averted 25 hospitalizations after we started reporting in 2008, and more than $18 million saved since our first report. So, thank you. So I just have a few summary thoughts. Basically, the health and healthcare workspace and landscapes are very complex. And having this constant vision as to where you're going is important. I'm increasingly impressed with the constant vision that we're getting at the state level, but it's in the context of a transition from fee-for-service medicine and paying for volume of services to a completely different approach and much more accountability. Transparency with trusted data motivate change. Tom ends up being sort of the arbiter of what's trusted. We've never lost data. Nobody's ever challenged data. We've challenged people's reports of their data oftentimes to say that they are doing better perhaps than they have reported. I think improvements in healthcare delivery and outcomes can be accelerated by social methods. The bright spots are in our midst. That's what Dan and Chip Heath said. That's what Jerry Sternin said. We are looking to ourselves, and this is sort of a social experiment to essentially utilize the collaboration of competitors to identify best practices and distribute them more widely through the region. And then finally, I do believe that while the social determinants of health, education, poverty, substance use, living, parenting, et cetera, are very important determinants of health, that healthcare delivery per se can improve the health of the population and reduce the costs of care for everyone. So I'd take a couple of questions if we have time. Norma? Right. Thank you. So there, Dr. Boutros. So, knowing that there's no more time, is that right?
Yeah. So depending on your answer, I'm going to go back to Long Island or stay in Cleveland.
No pressure.
So Dr. Cebul, obviously, you know, I'm a real fan of your work and also of Better Health Greater Cleveland. You spoke about positive deviance, and you and I have spoken about ignoring the middle, right? So
nothing interesting there, right?
Right. There's really nothing interesting in the middle. So what I wanted to talk to you about and I wanted to learn from you is that as you're improving, how are you contrasting the positive deviance and the negative deviance to find out what behaviors folks are utilizing, both patients and practices, to improve on the care?
Thank you. So I think that, so the question is, you've got to just think about this Gaussian or normal distribution. You got the high-end outliers, the positive deviance, and then you've got the negative deviance. We agree that the middle doesn't really give you much information about what works and what doesn't. It's the high end that's likely to be more enriched with good behaviors, good practices, and that the low end, you're either good behavior, good practices, bad behavior, bad practices, bad delivery system, bad patients, bad environments, any number of things. So the question is, why not, or how much are we attending to the low outliers? I would say not so much. We're in a very competitive marketplace. In the 1990s, there was something in Cleveland called the Cleveland Health Quality Choice Coalition. They basically did statistical Z-scores and showed you are better than average or you're worse than average. People didn't like to be worse than average. People didn't like to be in the newspaper as worse than average. And so we've sort of tried to keep this as a very positively framed thing. We are sending coaches like Bonnie and Linda Stokes and other people here we're sending them out to the practices that are performing least well and helping them to do better on the metrics and the standards that they're not doing as well on. But as Tom said earlier, we think that everybody who's publicly reporting are the good guys. And so we'd like to keep this a positive frame and enable everyone to very willingly and welcomely publicly report.
Thank you.
Sure. Thank you. Other questions? Ron?
So the question I have for you is those systems that aren't doing well,
Are not.
are not doing well, what is happening from a leadership perspective to bring those numbers up?
It's a good question. I think it is leadership. I think that when you talk about, and when we talk about, we helped get NCQA recognition for patient-centered medical homes. Those are mostly check boxes. Those are mostly, you have this structure in place, you have this structure in place, you have this process in place. But the real issue that you're alluding to, I think, is culture change, and it's really much harder to affect the transformation of a culture, and that's leadership. It's leadership, and it's teamwork, and it's willingness to hear from the people on the front lines and so forth. And so the places is Gene here, Gene Polster, I think it's our. So Gene, I mean, outstanding executive for neighborhood family practice. You look at it, sort of employee satisfaction kinds of ratings or evaluations of where they're working. They love it, and they're all feeling engaged, and that's because of leadership within the organizations like that. Thank you.